Now, Rangasayee Ramakrishna. Where is Jatya?
Sir, at the outset, I would like to make it clear that most of my observations will pertain to the pre-Modi ji era, because we have inherited that legacy and we are transforming the whole economy, and it will takes time. So this is more like Abhi Ghulam Nabi ji was taking an audit of our government implementing the schemes which they had given. Now I will tell what we had inherited and how we should either abandon them or improve on them. And I have great faith in my esteemed friend Naddaji's stewardship of the health sector, and I am sure he will respond positively to my perceptions. The draft National Health Policy 2015 envisages raising public health expenditure progressively to 2.5% of GDP. Currently, it is around 1.3 to 1.4%. The current year budget is an initial baby step in this direction, since it has raised the 2015-16 level of 33,282 crores to 39,932 crores in the current year. More significant are the big ticket announcements in the current budget of a new health protection scheme which will subsume the Rashtriya Swasthya Bima Yojana and give a universal insurance cover, up to 1 lakh rupees per family to each BPL family. Besides, an additional top-up cover of 30,000 rupees to senior citizens in the family. The opening of 3,000 additional Jan Aushadhi stores, providing for sale of subsidized generic drugs. I'll emphasize on this thing a little later in my intervention. And a new national dialysis services program for easy accessible outreach of dialysis facilities extending up to district hospitals in the PPP mode. What are the challenges before the health ministry? The health scene is vastly changing. Barring pulmonary tuberculosis, communicable diseases are not that aggressive these days. But it has given space to 3 major killers, namely cardiovascular diseases, which is 24% of total mortality, chronic respiratory diseases, which is 11%, and cancer, which is 6%. In the 5-year period between 2009 and 2014, major surgeries, that is surgeries involving total anesthesia, registered huge surges, and I'll give the percentages, it will be astounding. A surge of 979% in Maharashtra, 470% in Karnataka, 400% in Bihar, 509% in Chhattisgarh, and 494% in Andamans. This increasing trend is this is the reason why the doctors very easily resort to cesarean births rather than normal births and hysterectomies as a matter of routine. Apparently, there is also avoidable misuse due to the lure of insurance-based schemes. But the significant signal that is generated by these statistics is that preventive care and early diagnosis are taking a backseat, due perhaps to acute shortage of staff, particularly in rural areas, and the consequent thrust by private hospitals for easy resort to tertiary care interventions like surgeries after neglecting primary and preventive health care. That brings me to a central point of my intervention. There is a dire need for spreading public awareness of one's own anatomy and basic understanding of an early self-diagnosis. It's a well-articulated health research which says that substantially one's health is the resultant of one's DNA and one's genes. Ailments like diabetes and hypertension are broadly inherited. It is here that one feels that the still largely prevalent pattern of arranged marriages in India ought to be based more on DNA matching rather than horoscope Janapantri matching. There is a dire need for proper health record. This is the most significant minus point in our entire health system. Every time you go to a doctor, you have a new prescription, new test listing, but they don't even check out what is your the existing parameters. I will give an example. In the early 70s, almost 50 years back, I was working with the Economic Commission for Europe. At that time, they initiated a project for East-West trade cooperation. At the time, there was no trade between the socialist bloc and the Western bloc. And I was one of the team, and I made an in-depth study of the complementarities of two countries. One was Poland, which, despite its collectivist features, had still retained private ownership of farming. The other one was Sweden, since that was a market economy, but it had built up a welfare edifice where the state was directly responsible for areas like public health and transportation. In Stockholm, I studied the working of Danderyd Hospital, which was a central hospital of Stockholm, which catered almost the entire citizenry of Stockholm. The chief executive there was not a doctor. He was a clinical psychologist. And it is a very interesting thing. Almost in every patient's, separate room, a separate cottage, he had provided a small a kitchenette where the patient himself can cook his food. His argument was that most of the inpatient the illnesses, they will be cured if you are mentally active on other things. Particularly cooking sort of makes you forget your illness and you get cured easily. Now, this was an era when computers had still not arrived. I'm talking 1970. That hospital had the basic health data of every single citizen of Greater Stockholm stored in punch cards. Any patient who accessed the hospital had his diagnostic symptoms coded and fed into a punch card, which was matched with his basic health data in the hospital. The first diagnosis and the first prescription was actually done by the punch cards, not by the doctor. Now, this gives me an idea, although it's a massive organizational challenge which we have, we should have the basic health parameters data of every citizen digitally stored, like weight, height, blood data, blood sugar, lipid profile, kidney, liver function data, base ECG echo reports, urine analysis, etc., etc. This will substantially reduce the ill effects of the prevailing doctor-pharma nexus, on which I'll dwell a little more at length. Once a year, the data can be updated by holding health data camps. Unnecessary costly diagnostic tests and mindless prescriptions without an understanding of the patient's other health parameters and consequent side effects can thus be minimized. In my own experience, a few years back, when my doctor shifted me from one branded drug to another. And I suffered for almost 6 months with inexplicable giddiness and vertigo, for which I went through dozens of costly scans, MRI, etc., etc., but with no clue. I happened to attend one of the orientation lectures when, lo and behold, I learned that the new prescribed drug had a major side effects of severe giddiness and vertigo. Back from the lecture, I cross-checked with Google. Google confirmed this thing. I discontinued the drug. I became totally all right. And from that time onwards, Google is my personal doctor. I don't depend too much on doctors. Now, I refer to this experience since it underscores the need for a regular health card system which can be easily designed and updated with increasing digitalization network connectivity in our country now. The basic stored data will easily indicate which patient is prone to what disease. This will negate the need for more and more test reports and more complex and costly diagnostics. That brings me to another major issue. The current rules of business allocation needs drastic correction. An ideal Ministry of Health should be in charge of the pharma industry also. We have a very peculiar division. Pharmaceuticals is being looked after by the Chemical and Fertilizer Ministry, and the Health Ministry is emasculated in this thing. I was a member of the Standing Committee in Commerce, which gave a comprehensive and very mind-blowing report on FDI in pharma sector, which is the 110th report, which was given in August 2013. In its concluding para 39, it states that the committee is of the considered opinion that since medicines and drugs are an integral aspect of public health structure, the Department of Pharmaceuticals should be subsumed within the Ministry of Health and Family Welfare for effective policy formulation and monitoring of pharma sector in larger public interest. This is a very big lacuna. Now, I have some very close relatives, my nephews and nieces, who are doctors practicing in the US. There, the FDA, the Foods and Drugs Administration, subjects them to periodic evaluation of all their prescriptions to assess whether medical practitioners overprescribe, also whether they tend to be influenced by particular brands. Unless our medical council does some such thing, the nexus cannot be broken. Periodic orders have been given mandating generic prescriptions. Even last, I think after we gave the report in this very same report, even CGHS gave instructions for generic medicines. But it was followed more in breach. Sir, I have not have time. I'll complete. The Standing Committee report also mentioned that Tamil Nadu and Rajasthan Medical Services Corporations, they have been able to procure generic drugs at prices 50 to 60 times less than the retail prices of brands made by market leaders. There is a very interesting case study which we made in that committee, that there is a Bayer's anti-cancer drug, sorafenib, and that drug was being sold at 2,80,000 rupees per month for a patient, cancer patient. And using the Section 84 of the Patents Act, the Supreme Court ordered a compulsory licensing. And the compulsory licensing allowed one NATCO company to make the drug available at what cost do you know? 2,80,000 was the one prevailing earlier, and this company made at the 8,400 the same drug. Now, the fact is that the FDA in pharmaceuticals has played havoc since hardly any investment has come in the greenfield route. The same standing committee had recommended a blanket ban on brownfield FDI. Nothing has happened. I will cite one of the many examples of cartelization arising out of the takeover of the Indian pharma companies. Almost all Indian pharma companies have now been taken over by the Western companies. This is about a case study which we looked into of Rangasayee merger with Daiichi Sankyo, which led to the immediate withdrawal of all patent challenges by Rangasayee on Pfizer's blockbuster medicine Lipitor in 8 countries. They had to withdraw the patent application.
पूरा करिए.
I'll come to medical education, which is the real villain of the piece. It's a monumental mistake. The capitation fees collected has ruined all prospects of providing affordable health care to the masses. We should have confined medical education to be provided only by the state, leaving the field open to private sector only to provide hospitals. A bond for serving in rural areas should be made a rigid condition. It's also a criminal waste of scarce resources to permit medical graduates to compete for civil service examinations.
अभी दो और वक्ता हैं आपके, इसलिए
Just 2-3 minutes.
प्लीज कंटिन्यू.
Health insurance has so far not taken off at all. So there is a huge disconnect between the notional coverage and the effective coverage. Only 1.2% of the hospitalization cases of rural population and 6.2% of the urban population have received even part reimbursement. Looking to the totality of the situation, the poor seems to turn to subsidized care in public hospitals, and that too provided these services available nearer their homes. The UK model is one of a national health service where government sets up hospitals and provides comprehensive health service to citizens. The American model is one of insurance-based health care, but that's a model which gives insurance coverage even to non-hospitalized outpatient diagnostics and medicines. But since Indian pharmaceutical industry seems to have lost out to foreign multinationals, the cost of medicine diagnostics have steeply increased, and consequently the insurance industry will be more geared to the rich.
Thank you.
So, I mean, I have still some more, but okay, I'll
Give to other speaker
you.
so that हो तो समय तो जितना है उतना
And
है.
I earnestly hope that Naddaji takes stock of the above situation and creates a new healthcare architecture in the national health policy which he is currently examining. Thank you.
धन्यवाद.